Hello, my name is Ian McCall, and this is another of the consultations in dermatology from the Australian Institute of Dermatology. What we're going to talk about tonight are factitial scars, or dermatitis artefacta. Now, these are lesions that are induced by a patient, and as such, they have certain characteristics. First of all, these lesions are often geometric in shape, they're often sudden in onset, and they often show skin necrosis, or at least skin bruising. The patient may show a phenomenon called belle indifférence. In other words, they don't seem as anxious or as worried about it as you might expect from the nature of the lesion. They typically are seen in females, and I think it's Shelley who describes them as being particularly seen in adolescent women, nurses, and nuns. Now, I can certainly vouch for the first two groups, but I haven't seen many nuns with dermatitis artefacta. It may depend where you practice. Shelley, in his original description of this condition, referred to the phenomenon of cutting. And this is a phenomenon that we certainly see in adolescents. And if we have a little look at this image here, you can see what he was talking about. These are the small superficial cuts, very superficial. There's nothing deep about these. These aren't going deep to damage blood vessels or the like. They're tentative small cuts on the surface of the skin. And you can see how marked they are on the other side. Now, this isn't really an adolescent, not with all those rings and the like there. So it affects adult women as well, but we are seeing an epidemic of it in adolescents at this time. It's a cry for help. It's a measure of the underlying anxiety or depressive features or some other psychopathology that the adolescent suffers from. And it's much the same, I think, in all patients who have dermatitis artefacta. You have to ask, what's the problem? What's the psychopathology that's making them injure themselves like this? Is it to bring attention to themselves? Is it to reflect an unresolved internal conflict? It's important that you try and establish that, because one form of injury may lead to another form of injury. And it may be a presentation prior to a suicidal attempt. Let's just go back and look at some of these other images. This was a young lady who presented with these curious triangular or diamond-shaped bruised lesions on her anterior chest wall. The fact that it was a bizarre shape instantly made one consider artefactual injury, but it was difficult to know quite what she had used. Pinch purpura, where you pinch two surfaces of skin together and press them, doesn't give a picture quite as angulated as this. Of course, the girl's mother was concerned that she might have had leukemia, but blood tests and the like showed there was no abnormality like this at all. Her platelets were quite normal. And the abnormal shape made the issue of dermatitis artefacta highly likely, but her parents didn't accept that diagnosis. In fact, were quite resistant to it. The young lady was subsequently admitted to hospital under another physician, and it was there that she was observed injuring her skin and causing these lesions. So dermatitis artefacta it was. Here's another case, though, that would be more difficult to diagnose as dermatitis artefacta. It's on exposed areas of the skin. There are erosions, but there are a variety of potential causes for conditions like this. And so it would be very difficult to make a diagnosis of dermatitis artefacta from that. It would be a bit easier from something like this, where you have lesions at different stages. You've got blistering here, you've got necrosis and ulceration here, and very sharp edges, where something's been applied to the skin and it's caused superficial skin necrosis all the way through. In this particular area here, it's just causing blistering. But this sort of shape would be highly suspicious. Here was another case I had just recently where, again, full thickness skin necrosis here, And the varying shapes of these lesions were suggestive of something necrotic or acidic being dropped on the surface of the skin, causing this type of injury. You'd have to consider a condition called porphyria cutanea tarda here, but that usually gives blistering. It's due to abnormal breakdown of the hemoglobin molecule, giving porphyrins in the blood, and these porphyrins react with 400 nanometer wavelength of UVA light, and it causes usually areas of blistering and erosions in the skin. But that certainly wasn't the case here, and this was another example of dermatitis artefacta. This one would be even more difficult to be certain about. Here you have deep necrotic ulcers, varying shapes and sizes, but this could be pyoderma gangrenosum. It could be due to severe polyarteritis nodosa or calciphylaxis of the skin. But dermatitis artefacta is still a possibility, depending on whether something's poured in the skin or something's injected into the skin. And a wide variety of things can, in fact, cause these. I mean, ulcers have been known to be caused by phenol, by silver nitrate, acids, alkalis, and even ice cubes applied to the skin can cause sufficient injury to cause ulceration like this. So you're not going to make that diagnosis of dermatitis artefacta unless either you see the patient doing it, injecting something into it, or you've virtually excluded anything else. Here's another one that it would be difficult to make the diagnosis as well. This could be a skin malignancy. It could be tuberculosis of the skin or some other deep mycobacterial, deep fungal or deep mycobacterial infection. You would need to do a biopsy across here to see what the histology was underneath. If something's applied from the outside, then you get necrosis of the overlying epidermis. If something is a process that's occurring in the inside, then the overlying epidermis may be intact and the damage is much deeper. This would be a difficult diagnosis to make for dermatitis artefacta. It's an vulval area, and you've got this sharply outlined necrotic area on one side of the vulva. That could potentially be a herpes simplex or herpes zoster that's caused this sort of damage. But it would need to be almost in an immunosuppressed patient to give that sort of picture. To give that degree of necrosis, you would have to be immunosuppressed for the herpes virus or the zoster virus to actually do that. But this was in fact dermatitis artefacta to be induced by the patient. Blisters, again, difficult to make the diagnosis. It could be a fixed drug reaction here. Could be pseudoporphyria. But in point of fact, it was a substance applied to the skin, because if you looked at the overlying epidermis here, it was all necrotic. Whereas with fixed drug and the like, the overlying epidermis is intact and the blisters are occurring at the dermoepidermal junction. So biopsies can be helpful if you're trying to make your diagnosis. This was just the anterior view of this particular patient, where again you can see where something dripped and run along this part of the skin here, causing some early blistering. This would be awfully difficult to diagnose as dermatitis artefacta. I mean, that could really be a fixed drug reaction, a localized area without too much in the way of perilesional erythema with blistering. You would need to biopsy this to see if there's overlying cutaneous necrosis, epidermal necrosis, or if all the damage is at the dermoepidermal junction. Young person, as you can see. That's more likely to be dermatitis artefacta. It could be eczema, Pseudomonas septicemia, some other type of fungal mucor, necrosis of the skin, but again it would have to be an immunosuppressed patient. So skin biopsies would be useful. Blisters, by the way, can be due to things such as catharidin, which is from the blister beetle. Sometimes blisters can be due to cigarettes, but cigarette burns usually give areas of necrosis somewhat like this, not like this, but individual lesions like that could be due to cigarette burns. Here's a young lady with linear purpura. You don't usually get that. You may get it obviously from scratching or from something else, pinching the surface of the skin to give that sort of pattern. Linear purpura you don't get other than from scratching. There are a variety of other conditions that can be associated with that patients induce in themselves. This is trichotillomania, where a young child's been pulling away and breaking the hairs, pulling the hairs out in this abnormal sort of pattern. It's not alopecia areata. The other hairs here are quite intact and not loose or that at all. This is marked prurigo nodularis, where some people, when they pick and scratch at the skin responds by forming these thick, scaly nodules. They're very, very itchy. It's a form of lichen simplex chronicus, and it just instigates further scratching and further irritation, so that the lesions thicken up like this. But this isn't bizarre, or at least it's not to a dermatologist. He recognizes this for what it is, self-induced scratching of the skin. But that's a different condition to our dermatitis, true dermatitis artefacta that we spoke about with this particular lesion here, where the lesions are often sudden onset, geometric in shape, and usually, as I say, there's skin necrosis like this one, especially when something's been applied to the skin. My apologies. A dermatitis in the skin can in fact be induced by sandpaper or strong soap or things like that. So even things like dermatitis have to be considered sometimes as being a form of being dermatitis artefacta. And there are a variety of things that can be injected into the skin as well. There are other conditions, though, just to remember. I've talked about polyarteritis nodosa and ulceration. I've talked about porphyria cutaneous tarda, blisters and erosions on exposed areas, pyoderma gangrenosum for that one with the ulcers on the legs. And if you get an area of necrosis, even something like this, although you wouldn't get these, you've got to think of warfarin necrosis or heparin necrosis with a protein C deficiency and a vasculitis-like picture that gives a big area of skin necrosis. So you've got to watch that. You've got to have a wide knowledge of medicine and dermatology to be able to confidently diagnose dermatitis artefacta, because there are many other things in medicine that can look like these self-induced lesions. But remember, they're sudden onset, often skin necrosis, geographical sort of shape, very well outlined and defined in most cases. So you've made your diagnosis of dermatitis artefacta. The next important thing is to find out the reason why the patient's doing this. It's not enough just to dismiss them and say, look, you're doing it yourself, stop it. There's a question of trying to explore why that's happening. And it's very important that you do this, or if you're not capable of doing this, refer them to a psychiatrist or another doctor who can, in fact, explore the reasons for this happening. Because it's a very sorry existence that someone must have when they're so psychopathologically affected that they feel they have to injure their skin to either bring attention to themselves or indicate that they are under a lot of stress. And this sort of thing can happen in adolescents who's been sexually abused, where they can't talk about that, but they injure themselves, and that brings them to medical attention. And perhaps they are then able to explain why they're doing it to themselves and what the underlying problem is. So dermatitis artefacta is but a superficial diagnosis. You've got to go to the deeper psychopathology that allows this condition to manifest itself in that individual. So complex condition, complex cases, and the prognosis is always a bit guarded. Thank you very much.